All right. If I may, I'd like to introduce Zack Stoycoff. Zack is the executive director of the Healthy Minds Policy Initiative, and he'd like to make a brief address. Zack?
All right, can y'all hear me? Well, thank you, Dr. Crawford. We are so proud to partner with you and OFIC. This is a really important retreat, and we've got a lot to talk to you today about. Dr. Crawford, I don't know, an eclipse and sirens, and if somebody breaks a leg today, we're at least at a medical center, you can maybe get some help. To quote one of my favorite, we planned it all. To quote one of my favorite fictional characters, Dr. Crawford, I'm not superstitious, I'm just a little stitious. All right. Might not be doing this right here. Oops. Sorry, my technical wizardry is on full display here. Oh, okay. Thank you, appreciate it. That's your. Yes. Okay. And then we're going to go back to Zoom real quick and make sure we're sharing. Sorry about that, everybody. All right, so I'm here to give you a little bit of a brief overview on sort of a state of mental health in Oklahoma and talk to you a little bit about what Healthy Minds works on. You'll hear from at least one of our folks later today, too, on some policy issues that are facing Oklahoma, but let me give you a brief update and an overview. So Healthy Minds, as Dr. Crawford mentions, is a mental health policy think tank. We work on policy, legislative, and community solutions driving mental health change in Oklahoma. We seek nothing short of an end to untreated mental illness and substance use disorder in Oklahoma. It's a pretty lofty goal. We do that through a number of ways. If you ever go to our website, healthymindpolicy.org, we put out copious amounts of research trying to understand the system and the gaps in our state. We also work directly with legislators. We manage a state legislative mental health caucus of about 30, 40 legislators who get together and talk about solutions, and we pass legislation. We passed 10 bills in the last 4 years, focused on everything from mental health parity to workforce development. And we work on collaborative partnerships. For example, in Tulsa, we're leading what we believe would be the first in the nation effort to produce a zero overdose community, which is modeled after zero suicide, as was mentioned today. And we can talk a little bit more about that offline if anybody is interested. So doing all of this and the leadership that we have, the 20 plus people that we just deploy day to day, 24 hours almost, at least in my head, working on solutions for the mental health system in Oklahoma, we often do get asked, what is the solution to mental health in Oklahoma? We've got a crisis. What do we do about it? And I certainly wish there was a silver bullet. There, of course, as you all know, is not a silver bullet. The answer is very simple, though. We simply need a highly coordinated, high fidelity continuum of care that is seamlessly connected with the general healthcare system. That's really easy, right? We can do that. For those of you who don't know what an evidence-based continuum of mental health care looks like in Oklahoma at Healthy Minds, this is how we perceive it. Steps along the continuum of care, starting with certainly a base of universal prevention and promotion, going right up to what we would say primary care's role is as an entry point into the treatment system. Primary care is an entry point in the treatment system for general health care, but often is not an entry point in the treatment system for mental health care, unfortunately, and we want to change that. But say you go up to, we all know, outpatient therapy, but all the way to inpatient care. And unfortunately, what we've done historically across the country, of course, as you probably know, is we've invested in the FHIR. We've put so many resources on the sort of the back end of this continuum, inpatient and residential care, where it is often more harmful than not to put somebody in a treatment setting who doesn't need that level of care. But that's where we put the resources. That's starting to change in Oklahoma. And this conference is about primary care. And we really think that this is part of the solution, a big part of the solution. We'll talk about why. Oops. Excuse me. So what's wrong with primary care? Well, I know some of you work in primary care, so let me tell you really quickly, you all do amazing work. We're very proud of our primary care physicians in Oklahoma. And when I speak about what's wrong with primary care, I'm really speaking generally and historically. So we know that research will tell us about 60% of behavioral health conditions can be treated in the primary care setting. Mild and moderate conditions can be treated in the primary care setting. Why is that important? Well, it's important because you may know that we have a shortage of mental health specialists across the country and certainly in Oklahoma. There's not enough people to refer to. It's also important because at the height of the pandemic, about 1 in 2 Oklahomans experienced a diagnosable general anxiety disorder or depression. 1 in 2 of us. In normal times, it's about 1 in 5. Those prevalence numbers are still a little bit elevated. This is a critical issue for our time. It's affecting almost every single family that we encounter in the primary care setting. We cannot ignore it in the primary care setting. You all are wonderful people and you don't ignore it, but understand that I'm talking generally and historically. But there's a lot of research that shows that we're not really doing what we need to do. About 1 in 2 people who had died by suicide in this country, almost 50%, had seen a primary care physician in the last month of their life. That's interesting when you look at this other data, completely different research that showed 47% of cases of depression who walk into a primary care setting are detected. Only 47% who walk into the door, we even catch that it's there in the primary care setting. And then 24%, barely a quarter of people, not even a quarter of people who walk in the door with depression are treated. Go down that line, are they treated adequately? No, they're not. Less than 10% of them are treated adequately. We're not doing a good job generally and historically. And that's got to change. There's a lot of cool ways, and we're going to talk to you about some of them. Models that make this easier for primary care physicians, models that make this potentially profitable for primary care physicians to help to serve a vital part in the mental health continuum of care. The collaborative care model is a wonderful model that's got nearly, I think more than, at least now, more than 70 randomized controlled trials showing it improves patient outcomes and costs. It's amazing. We're going to talk to you about that later today at this conference. But this is why it's such a part of the solution in Oklahoma in particular. We would never advocate for training fewer primary care physicians. Primary care physician workforce is one of the success stories of of healthcare policy generally in Oklahoma in the last really decade. We've trained so many of them so well, we're actually exceeding the national average now in Oklahoma. Can you believe that? We're more than 40% more primary care physicians per capita in our state than the national average. When you look at HRSA's research on how many you would need per 100,000 people, we actually even exceed that. Not that every county in Oklahoma has enough primary care physicians, certainly don't get me wrong, but as a whole, as a state, we've done an amazing job. And now we've got to make sure that, again, 60% of cases can be treated in the primary care setting. Is this workforce part of our mental health care workforce? Because again, 1 in 2 people had a diagnosable condition, 1 in 2 in the last few years. So it's got to be part of the mental health care workforce. Look at psychiatrists. We have a huge shortage, as those of you who know, if you're trying to refer to a psychiatrist, you of course know. If you run a behavioral health institution, I think a couple of you do in the room. Welcome to our behavioral health partners. I'm glad to see you. You know that there aren't enough psychiatrists. Well, in Oklahoma, we have about 10 psychiatrists per 100,000 people. And nationally, there's about 13. Guess what? HRSA says you need 27.7 per 100,000 people, psychiatrists practicing. 27 per 100,000 people. We have 23 psychiatric residencies in Oklahoma and 4 training institutions. To even reach 13 in the next 10 years, we would need to more than double our psychiatric residencies from 23. We need to add 28 on top of that to even reach 13, which is nowhere near 27.7. We've got a long way to go. There are solutions here, and we've got Takia was mentioned earlier. She's our project director of behavioral health workforce, working on some research and some legislative proposals to try to get us some solutions on the workforce side. But we know that if you're doing primary care well on the mental health side, you're eventually going to encounter someone who needs a referral, and we want you to have those referrals, and that's important. There are certainly many other types of behavioral health practitioners that are critically important, as you know, master's level, bachelor's level, even peers, peer recovery support specialists who have lived experience, particularly on the substance use side, our research shows are critically important in the treatment process. But here you have a chart that shows you what HRSA says we need in terms of this category of professionals per 100,000 people, what the national supply is in green, and then what the state supply is in Oklahoma in blue. What's interesting is you look at down the bottom, we have far more LPCs than either the national average or what HRSA says we need. We're really getting into the bottom of this and at Healthy Minds. We've studied, we've researched this profession, we've talked to them. A lot of LPCs aren't actually practicing. A lot of LPCs aren't available on your network insurance plan. We'll talk about that in a second. So it's not like this workforce is readily accessible. On the social worker side, we're actually only meeting about 68% of the need. And psychologists are even worse. So we've got to do some work really bringing forward these sort of critical specialties that do things that only those professions can do. So again, there's an intrinsic issue here. I referenced it just a minute ago. Mental health parity says, particularly payers cannot treat behavioral health conditions any differently than they treat physical health care conditions in terms of putting up barriers to care. Barriers to care exist on the behavioral health side that don't exist on the physical healthcare side. This has been studied over and over. Insurers will put utilization review requirements and apply them differently on the behavioral health side than they do on the physical healthcare side. It's pretty common if you run an inpatient behavioral health facility to see a substance use disorder patient's treatment cut off after a certain number of days, even though the psychiatrist says this person's going to die if they don't stay longer. As in my medical opinion, the insurer will say, sorry, our criteria say that they no longer need care. Well, does that happen for a cardiology patient who's had a heart attack, who might have another heart attack? No, it doesn't happen. The research shows that it's totally differently applied. And that happens all over the place. In Oklahoma, we wonder why we don't have enough behavioral health practitioners. Well, research shows that insurance pays about 27% less on average to behavioral health providers than to physical healthcare providers. These are systemic issues. No insurance company is bad. These are things and programs and systems that have grown up over time. Yes, bad things happen, especially involving insurance, but it's not like there's a malicious cycle. Don't take that from this. There is a malicious cycle, but maybe not intentional. We're working with insurance to try to fix it. We've actually conducted some studies about insurance programs in Oklahoma. Health Choice on this chart here is the state employee network. Private Health Plan B is a large statewide insurance network that, due to partnership reasons, we will keep their name out of this. But this shows the number of behavioral health, the percentage of the state's licensed or credentialed behavioral health providers who are represented in that plan. So when you talk to insurance companies, you say, well, there's a reason why we can't offer great behavioral health care because there's not enough behavioral health professionals. Well, that's true on one hand, but on the other hand, you're including only about 30% of the licensed behavioral health professionals in your network. Why are you including only 30%? When psychiatrists will tell you the rates have barely been increased for the last 10 years. I mean, there's these issues that we've got to address. We can have solutions right now with the workforce we have right now and make things better for patients. In our network adequacy study, we actually called behavioral health practitioners who were listed in insurance networks. We can only reach 35% of them. So we're a little bit probably more educated about how to do this than the average consumer. Guess what? 30% of the people we called, the providers who were listed in the networks that are provided to consumers, 30% of them couldn't be reached. Many of them because of disconnected phone lines. This is a well-studied national issue called ghost networks, where insurance companies have not maintained adequate networks on the behavioral health side. It's irrefutable. The data is here. We've done it in Oklahoma. It's been proven nationally, and we proved it in Oklahoma. We've got to do better. The state legislature fortunately agreed with us. We worked with the legislature last year to pass 2 bills that, frankly, we think lead the nation in trying to address this issue. One bill actually required insurance companies to pay for out-of-network behavioral health care if that patient is unable to find a network behavioral health practitioner in a certain amount of time, and we defined it in statute based on national best practices, 30 days for outpatient care, for example. But we talk about Medicaid and low-income healthcare a lot in the healthcare policy space. More people have private insurance than Medicaid in Oklahoma, and certainly 2 million of us. So this is a major issue to our continuum of care. We've got to address the fact that providers are not in network. And when you talk to providers about why they're not in network, pay and runaround and bureaucracy, these are the things that come up. We can do better. We can definitely do better. Just a couple other quick things. Many of you may know that the state has a single crisis phone number that has replaced the National Suicide Prevention Line with, instead of a long phone number, a short phone number, 988. You can call 988 and talk to a crisis professional. In many areas of the state, you can get, if needed, a mobile crisis deployment. But what's really important here is that we used to only have to rely on the emergency room for immediate mental health crises. And the emergency room is really not the place for an immediate mental health crisis unless you have cutting or you've ingested a pill or there's some reason medically that you need to be seen by a physician. If you need to be seen by a mental health practitioner, we have, and fortunately the state is building out crisis centers, even in rural areas, urgent recovery centers. 24/7 is the goal that these centers are open and they provide immediate mental health care for those in crisis, and they connect you to an evidence-based path of diversion that will keep you out of hopefully jail, which is where you go if you often don't encounter the crisis system or an ER inappropriately, or you end up in that inpatient bed and you may not actually need it, like I talked about earlier. So one of the things we do at Healthy Minds, we certainly support the state's deployment of crisis services statewide. We work at community levels, for example, in Tulsa and in Edmond nearby here, to facilitate groups that talk about law enforcement assisted diversion, getting out of the ER, diverting to the appropriate crisis center in those communities and things like that. You can solve a lot of mental health crises actually without even law enforcement involvement, which is great. Another key point to remember though is that a lot of these folks, substance use disorder is of course involved. And in Oklahoma, that's largely meth. We talk a lot about fentanyl these days. That's a lot of it. There's a lot of co-use of meth and fentanyl, but meth is driving the overdose rates in Oklahoma. You can see this chart here. The green bar is one of the best success stories we've ever had in Oklahoma in substance use disorder policy, prescription opioids, because of the changes that were made legislatively and the progress that was made in policy worlds. That green bar has gone certainly down, but then of course the illicits have replaced it. But methamphetamine has gone way up. Do you remember when we used to make methamphetamine in Oklahoma? I was a breaking news reporter for the Tulsa World newspaper, going to work at 5 a.m. listening to the police scanner. And I remember every morning early in my career, we would have a house fire, a meth fire. Every morning it would be reported. You don't see that anymore because we're actually importing it from Mexico and it's even worse and more deadly than the kind that we would make here. So in Tulsa, we've got a zero overdose group. We've got a methamphetamine group that is working with dozens of community partners to actually provide diversionary treatment, increased treatment and bed capacity for methamphetamine addiction, which is of course one of the hardest forms of addiction to treat. There's not a pill you can take to curb your meth addiction. Really talks about diving deep into your reasons why your drug career has progressed that far, and there's a lot of trauma involved with that. It's hard work, but the state is and the communities are working on it. And then finally, and I'll stop droning on, youth in schools. I really would be remiss if I didn't talk about that the children's mental health crisis may be the most important crisis that we're facing in healthcare in America right now. The U.S. Surgeon General has declared this a national emergency. Community leaders have stepped up and talked about the fact that in some cases, hospital emergency rooms are seeing double the number of youth from pre-pandemic that are showing up in the emergency room with suicidal thoughts or other mental health crises. In Tulsa alone, I was just looking at some statistics. We had an increase in psychiatric and inpatient admissions for youth of 117% pre-pandemic to post-pandemic. More than double. I mean, this is a major issue. Depressive symptoms and all these things have been going up for years prior to the pandemic. And then what happened? The pandemic hit, social connectivity was lost, all these protective factors were interrupted, and then it just went sky high. We work on this. We actually passed legislation recently that required every school district in Oklahoma to have a memorandum of understanding and a formal agreement with their community mental health provider or another mental health provider of their choice to work on a crisis plan for students. I mean, some of these school districts had never even heard of their local mental health provider, much less had a formal agreement with them. I remember when we passed this bill, we got calls from superintendents saying, we can't do this. There's not a mental health provider in my community. Well, guess what? The Department of Mental Health funds a mental health provider in all 77 Oklahoma counties. And now they know about it, and there are these wonderful, beautiful partnerships that are showing up. I'll stop there, but I'll leave you with a couple of resources. Of course, pull me aside anytime today if you'd like to talk. Pull Jessica Hawkins, our Director of Community and Systems work in Tulsa and Tequila. Pull them aside. Brittany Hayes, our Policy Director, will be here earlier. We're happy to talk to you about this. Go to our website. We put out a lot of research. Sign up for our newsletter. Get that research when it comes out. healthymindpolicy.org, and feel free to contact me via email anytime. All right. Yeah. All right. With that, I'd like to introduce a dear friend of mine, Jeff Dismukes, to come up. Jeff is the Executive Director of the Depression Bipolar Support Alliance. Jeff, did I get the A right? Jeff has been working in this space for a lot of years, has lived experience, and is really somebody who understands this system better than probably me and anyone that I know. So good to see you, Jeff.
I'll be brief this morning, but I wanted to share with you some opportunity for collaborative care and integrated care models and what this can mean, not just to behavioral health, but really to the entire medical system in Oklahoma. 24, 25 years ago, a young individual, mid-30s, presented to a cardiologist, very professional, highly educated, and very fit. Which, if you look at me now, it's hard to believe that I was very fit at one time. But I was having different types of symptoms that surely this is what's going on. It's a heart issue. and went through all the stress tests and everything else you can do. There's nothing wrong. And the cardiologist said, well, I don't know what it is. It's not anything to worry about right now. We'll kind of look at it. A few months later, I was suicidal. I had a complete breakdown, I guess is a word that we can use, but I had hit the wall. And what it turned out to be was bipolar disorder. And those early symptoms, had we had in place what we have now. So if you go into a primary care setting now, you're filling out all the different forms, which I'm looking up here at Jessica Hawkins, who helped make that happen in Oklahoma. And you would have seen some of the things on those forms to allow maybe better intervention. Again, we didn't really have that 25 years ago, but we've made incredible progress. And I do represent people with lived experience. And I can't tell you how many stories I get for people where primary care has been how they engaged with treatment services for depression, for anxiety disorders, and whatever that might be. So there's incredible opportunity there. And when we see how many primary care physicians we have in Oklahoma, and we see the siloed system that we've talked about for a long time within behavioral health, which unfortunately I see happening through the rest of the medical system now. Sorry, name tag got caught. I know that we have to do something about this. But 25 years ago, with us talking about this over the years, we're still running into the same thing. I have a young attorney who came to me a few weeks ago. She had been receiving care from primary care physician for the last couple of years. He had diagnosed her with ADHD, started treating her with medications. She started having continued problems. He upped the medications until she was finally hospitalized and was diagnosed with bipolar disorder. All that had been happening was fuel being thrown on the fire. And there was opportunity there to refer, to look at other treatment options, and it never happened. I have another case, which unfortunately also involves a family member, where a professional, a medical professional, was diagnosed as having anxiety. The minute that diagnosis happened, it blocked any other look at what might be occurring with her. It took a trip to the Mayo Clinic after 3 years to find out that she had blockages in her brain that was causing her brain to deteriorate. But that anxiety diagnosis stopped everything. There wasn't referral, despite the fact that the primary had said it's anxiety. There was no referral anywhere. Now, I know you don't have to have a referral to go to a psychiatrist, but her insurance system was stopping that from occurring. They were saying we had to have a referral, and it took a huge argument to get there. But there was opportunity. I think in most cases, we're going to see I think that primary care physicians know more now and are able to make those referrals, but we're still seeing these blocks in the system. When I was at Mayo with my wife, who this family member was, I remember as we were doing our exit interview, we're talking to a neurologist, and the neurologist looked at me and said, "What kind of doctors do you have in Oklahoma?" I kind of took that personal because my friends were physicians. My wife's friends were physicians. And I personally know several people who have done incredible things to advance medicine. But I've really thought about that. And the answer is we have the same doctors in Oklahoma that they have at the Mayo Clinic. What the Mayo Clinic had was a system, a collaborative model that we can replicate. And the other thing I noticed when I was at the Mayo Clinic that really made me think about Oklahoma was that the Zero family's name was everywhere. They're funding a health system in Minnesota. We can have that here. We can build the exact same thing. To me, this is not just a means to fix the medical system and to bring care providers back into the decision-making process and create this network that we need. This is an economic opportunity for Oklahoma. This is instead of a battery plant or a tire plant or whatever it is that we're looking for, let's invest in our medical system and create something that's going to benefit the state in multiple ways. This is what we need to be an expert in. Behavioral health, this should be a destination state for not just behavioral health, but for all medical issues. And we have the ability to create that here.